This is part 2 of Medicare Chiropractic Documentation Guidelines. If you haven't watched our tutorial for initial visits, please watch that tutorial first and then return to this tutorial. In this tutorial, we'll be talking about documentation required for subsequent chiropractic visits, maintenance care, and Medicare audit triggers. This tutorial is prepared using the Clinic Pro EMR and ICER2Go software for screenshots to illustrate the documentation required. Each subsequent visit has its own documentation requirements. On the screen, you see the list of documentation requirements for the ongoing visits. The first portion requires that you review the chief complaint and indicate changes since the last visit. The third sentence is another ambiguous portion of the documentation requirement. System review if relevant. A complete system review requires going through every system of the body and indicating changes in symptomology. We suggest that you perform a complete system review on the initial visit and on the re-exam visit. Prior to adjusting the spine on each visit, Medicare requires that you perform an examination of the area of the spine involved in the diagnosis and assessment of change toward accomplishing the treatment goals. In addition, WPS Medicare requires that the documentation reflect an initial visit date and a visit number for every subsequent visit. In other words, if your treatment plan sets up 36 visits, your documentation should reflect the fact that this visit is number 13 of 36. The Clinic Pro EMR uses a screen such as this to record your daily note. Referencing the chief complaint, you can record pain scale and changes in the condition. You can indicate examination findings and the level of the spine involved. Finally, Medicare requires that you document the treatment given. Since every chiropractor and chiropractic office is different, the way that the adjustment is documented will differ from office to office depending on the specialty of the chiropractor. The Clinic Pro EMR system allows you the flexibility to set up various screens to match your style of practice and your unique methods of recording your adjustments. When you've finished recording information, a daily note of a subsequent visit might look like this. Medicare does not require a 3-page note. They simply require that you document changes since last visit and treatment performed. Finally, let's look at Medicare's definition of maintenance care. In their own words, when further clinical improvement cannot reasonably be expected from continuous ongoing care, and the chiropractic treatment becomes supportive rather than corrective in nature, the treatment is then considered maintenance therapy. Since Medicare does not pay for maintenance care, you will need to have an ABN signed by the patient. An ABN is Advanced Beneficiary Notice. Any time that you suspect that Medicare may reject the services, it is wise to have the patient sign an ABN indicating that they accept financial responsibility if Medicare rejects the services. Everyone asks one final question. What will make me a Medicare target for audit, and how can I avoid triggering an audit? In some cases, you simply cannot avoid triggering an audit. In other cases, you do have some control. The first one on the list is treating more Medicare patients in a period of time, usually 6 months, than what is considered normal. If it is normal for a chiropractor to treat 25 Medicare patients in 6 months, and your office has treated 67, you may have the unfortunate experience of falling above the statistical norm based on the area of the country where you practice or the number of Medicare patients that are attracted to your office. Because we live in the computer age, Medicare can create all kinds of statistical averages and target offices that fall outside the statistical norm. The second trigger we've listed is excessive use of the AT modifier. AT means active treatment. It should only be used when the patient is in the corrective phase of care. Once a patient reaches maintenance care, services can still be billed, but they should include a GA modifier. This indicates that the office realizes that Medicare may not pay for the service and an ABN has been signed by the patient. A third audit trigger is a mismatch between the level of subluxation indicated and the neuromusculoskeletal diagnosis. If you've indicated a cervical subluxation and a lumbar sprain, it is an obvious mismatch. A fourth trigger is excessive use of the 98942 procedure code. This procedure code indicates that you adjusted 5 regions of the spine. It is much more common for offices to use 98940 to indicate that you adjusted 1 or 2 regions of the spine, or 98941 to indicate that you adjusted 3 or 4 regions of the spine. Another audit trigger would be a visit count that is higher than normal. Because Medicare compiles statistics from every office in the country, they can match your office against statistical norms. If your visit count is higher than normal, an audit can be triggered. The final known audit trigger is the failure to release patients from corrective to maintenance care. Medicare uses the duck method of determining maintenance care. If it looks like a duck, walks like a duck, and quacks like a duck, it must be a duck. If the patient is being seen once or twice per month, it certainly looks like maintenance care unless your documentation supports the fact that the patient is still making substantial improvement. Thank you for watching our Clinic Pro tutorial on how to pass a Medicare chiropractic audit. Feel free to visit our websites, clinicpro.com or chiropractic-software.com, to download a PDF of the screens in this tutorial. It is our goal that every chiropractor understands Medicare guidelines and knows how to pass a Medicare audit.